Welcome everyone to the first LactaHub Webinar on this year's World Breastfeeding Week. Thank you very much for joining in. I'm Arantxa de la Horra, Clinical Research Specialist at the Global Health Network and a midwife, and I will be moderating today's session. Today, I'm delighted to be joined by our special guests, Dr. Paula Maya and Dr. Shushma Nanja, as well as Kai Kushkau, Head of LactaHub, Janet Prince, Head of Relationship Management at the Family Larsson-Rosenquist Foundation, and Helena Wilcox from the Global Health Network. Our webinar today is titled Discover PROVIDE, a training compendium on providing mother's own milk in NICU settings. This webinar coincides with the World Breastfeeding Week and the launch of the PROVIDE Training Compendium, a new open access evidence-based resource produced by the Rush University Medical Center to help healthcare professionals bring life-saving mother's own milk to hospitalized infants. Today we'll explore information sheets, watch a sample video, training video, and hear first-hand user experiences from Dr. Shushma Nanja, a neonatal specialist in New Delhi, who I will formally introduce shortly. Before we begin, a few points of housekeeping. Please be aware that this session is for the purposes of sharing on LactaHub and the Global Health Network. We will open the floor for questions once each of our speakers has presented. Please use the Q&A box in Zoom to enter these questions, or for those joining via Facebook, please ask your questions via Facebook Messenger. The team will ensure that these are forwarded to the panel. We will cover as many questions as the time allows. If you have any technical issues, please type this in the Q&A box and the team will aim to assist you. The program for today will be as follows. First, Helena Wilcox from the Global Health Network and Kai Kushkau, Head of LactaHub, will give updates and an introduction. From there, Dr. Paula Maya will explore the PROVIDE Training Compendium. Following Paula's talk, Dr. Shushma Nanja and Janet Prince will discuss practical applications of the training compendium. Finally, we will open the floor to questions from all the participants. Now, I would like to introduce our special guests. Firstly, Dr. Paula Maya, who is the PROVIDE Training Compendium creator and professor of pediatrics and nursing at Rush University Medical Center. Since 1975, she has been a practitioner and researcher in the area of human milk, lactation, and breastfeeding for premature and other NICU infants and their mothers. Dr. Maya has conducted numerous externally funded research and demonstration projects. She was a principal investigator for a 5-year study titled Health Outcomes and Cost of Human Milk Feeding for Very Low Birth Weight Infants, funded by the National Institute for Health, which was the foundation for 2 additional NIH grants, including reducing disparity in the receipt of mother's own milk in very low birth weight infants. She has also published over 200 peer-reviewed manuscripts and book chapters. She is a former president of the International Society for Research in Human Milk and Lactation, has been an advisor to La Leche League International, and presented data from her innovative Rush Mother's Milk Club program throughout the world. I'm also pleased to introduce Dr. Shushma Nanja, Director and Head of the Department of Neonatology at Lady Hardinge Medical College and Kalawati Saran Children's Hospital in New Delhi. Dr. Nanja is a neonatal clinician, an academic, and a researcher. Her main interests are neonatal resuscitation, neonatal sepsis, neonatal respiratory care, breastfeeding and enteral feeding, science of human milk, along with human milk banking, kangaroo mother care, neonatal education, and epidemiology. Dr. Nanja is in charge of a university public health institution's tertiary neonatal unit with around 14,000 annual births and over 3,000 annual neonatal admissions. And her department runs a super specialty neonatology degree program. Now, I will hand the floor to Helena Wilcox from the Global Health Network to provide an introduction. Welcome, Helena.
Thank you, Arancha. I hope that you can all hear me well. Good morning or good afternoon, everyone, depending where you are in the world. And thank you very much for LactaHub for inviting me to speak on behalf of the Global Health Network today. And we're delighted to be working with LactaHub on this exciting project. I'll just spend a few minutes providing a short overview of the Global Health Network for those who haven't come across our work before. The Global Health Network is an integrated digital and face-to-face capability building program, and our overarching aim is to facilitate more, easier, faster and better research in the world's most challenging settings and the diseases that have a high burden in those settings. The way that we deliver this program is to facilitate health research and deliver research capabilities for research teams and for health professionals. The way that this is delivered in practice is through an integrated program of knowledge sharing hubs and capacity development and process improvement initiatives, which I'll talk about more in a moment. And why is this important? Because in 2013, the WHO said that low and middle income countries should be the generators and not the recipients of health research data. And there's some really stark statistics to support this statement. So 0.5% of new products in development are for the WHO neglected diseases. 7% of all research investment is focused on the WHO neglected diseases. And there are 45 times more health researchers in high-income countries than in low-income countries. Addressing these inequalities addresses and tackles 6 of the Sustainable Development Goals. And overall, this is what we're working to address, both on the skills and capabilities side, as well as the research side. Looking at our impact at a glance, in the 10 years that the Global Health Network has been active, there have been 28.8 million visits to the globalhealthnetwork.org, which is our digital tools, resources and professional development program and digital platform. Within this digital platform, there are over 265,000 registered members in this community, which represents a full range of research disciplines and roles in global health research, spanning different disease areas and different topics across the health research ecosystem. Within the Global Health Network's digital platform is an e-learning platform through which as of May, 1.3 million training modules have been delivered through this platform. The platform itself aims to promote knowledge exchange, and to that end, the Global Health Network, as well as many of our collaborators, use this as a platform to openly share templates, tools and resources, including protocols, case report forms and other research tools. And through this sharing, over 380,000 of those resources have now been downloaded. Across the platform are also sort of getting close to 4,000 different pages of guidance articles and blog posts of people sharing their experience of health research, providing support and working collaboratively with others across the world to support their research endeavours. You can see some of the different programs that we run in partnership with many of our collaborators, working on research skills, providing research tools, ultimately delivering impact to the areas that we would like to support improvements in. This is delivered, I mentioned the e-learning platform. We have a professional development scheme that was developed with WHO TDR, focused on clinical research competencies. We also work on several knowledge hubs and through our digital platform, which are open communities of practice where health researchers and health professionals can exchange their experience, their knowledge and their resources for their studies. We seek to use this platform to improve methods and processes and conduct analysis on what's needed to support those researchers and health professionals in their role. And we also finally have a process map which guides health professionals and health researchers through setting up and conducting a research study. And this slide is just a snapshot of a lot of what we deliver through the Global Health Network. And it's worth noting and emphasising that this is delivered in true partnership with over 70 collaborators across the world. So this integrated programme and what I and my role at the Global Health Network focus on is a knowledge exchange programme, and this is delivered through our online platform and through regionally based initiatives aiming to build lasting, capable teams who can deliver research excellence. To date, there are 52 knowledge hubs, each with its own overlapping and integrated community of practice, enabling health professionals and health researchers to exchange their experience and their expertise across disease areas, research roles, regions of the world, and across different organisations. I mentioned that how frequently and how often the platform has been visited, but this is also a research platform. By working with so many health professionals and health researchers, it enables us as a team and with our partners to understand the barriers and enablers to improve processes and ultimately support the uptake of research findings into policy and practice to deliver the improvements to health that the research is aiming to achieve. In summary, we're working to enable health research into the diseases, regions and community where evidence to change health outcomes is lacking. And that's reflected in the disease areas and the regions of the world that we're very active in. And by being active in these countries, we're applying our experience with the digital technology and the concept of communities of practice to facilitate the transfer of this expertise and experience. What we'd like to do going forward, and what we're increasingly doing, is using the network as a learning platform to determine the barriers and enablers to research, to drive faster methods, raising standards, and ultimately making research more effective and more accessible, making sure that that research can be conducted and the benefits shared in an equitable way across the world. And ultimately, it's really essential that we support and work with our collaborators to ensure that these findings are taken up into policy and practice to drive the improvements to health outcomes. Together, across all of our programs, the ultimate aim is to create equity and access to the benefits of research. And we're delighted to be working with LactaHub on delivering knowledge exchange, an open access knowledge exchange program, which Kai will speak about further in a few moments. So thank you, and I'd really encourage you to join the Global Health Network and LactaHub to learn more and to join our community, our growing global community. Thank you.
Helena. Now I'm pleased to introduce Kai Kushkau, Head of LactaHub, who will provide further background to this exciting project. Welcome, Kai.
Thank you very much, Arantxa, and thank you very much, Helena, for your kind words and your introduction of the Global Health Network. So we are one of the 52 knowledge hubs on the Global Health Network, and we are very young. I think we are one of the babies on the Global Health Network. LactaHub was launched 3 months ago. So this is the first product we launched, the PROVIDE Training Compendium, and we are very excited to have this webinar today. So LactaHub focuses on evidence-based breastfeeding and breast milk knowledge for health professionals, decision makers, and researchers, especially in limited resource settings. And it strives to become a central and trusted source for breastfeeding intelligence. Next slide, please. LactaHub aims to improve the availability, accessibility and use of scientific and evidence-based resources by aggregating a wide spectrum of content. For example, peer-reviewed research, key health interventions, and training materials similar to the PROVIDE Training Compendium that Paula introduces today. Further elements will be added step by step as LactaHub evolves. Next slide, please. We aim to capture and aggregate the content on LactaHub in a structured and practice-oriented manner and publish it open access globally. There will be an intelligent library with original papers, grey literature, an experience archive, and more other things. Furthermore, there will be a collaboration space and an education platform in the future as well. Next slide, please. LactaHub's goal is to provide breastfeeding intelligence along a knowledge value chain from knowledge discovery to knowledge implementation, with a special focus on knowledge translation. Knowledge translation is actually the bridge between knowledge discovery and evidence-based knowledge implementation. For example, it addresses the question, how does research finding become a health intervention for mothers and their children? Next slide, please. Consequently, LactaHub will address stakeholders who can put policy into practice, such as supragovernmental organizations, governments, and health professionals. LactaHub aims to support healthcare workers, decision makers, advocacy groups, community workers, and researchers, especially in limited resource settings, to be more effective in their daily work. Next slide, please. And LactaHub is a living platform that will never be finished. It is a growing knowledge hub which strives to become a sustainable and trusted source for breastfeeding and breast milk knowledge. Over the next years, LactaHub will grow. We aim to add new features and more content similar to the PROVIDE Training Compendium. So let me summarize with the last slide. As a central platform, LactaHub aims to simplify the search for information and streamline connections between people and knowledge. It improves the availability, accessibility, and use of scientific and evidence-based resources and objective research. It captures, aggregates, and shares content in a structured and practice-oriented manner and is continuously curated by experts. LactaHub is freely available worldwide. It enables health professionals, decision makers, and researchers to be more effective in their daily work and to connect to each other with their daily work. LactaHub will grow and evolve and strives to become a sustainable and trusted resource. So please feel free to get involved on lactahub.org. We welcome you to use this new resource for evidence-based breastfeeding knowledge and share your input with us. So thank you very much, and I'm very curious, Paula, on your presentation of the PROVIDE Training Compendium.
Thank you, Kai. Now I'm pleased to introduce Paula Maya, who will give us a tour of the PROVIDE Training Compendium. Welcome, Paula. We may have had some technical difficulties.
Here, yes, I was just waiting for the slides to load here. Yes, thank you everyone for joining us for the launch of PROVIDE, our training compendium on providing mother's own milk in the NICU setting. Next slide. So this is an exciting time for me because this is really a project that I probably thought about for the entire 4 decades of my career, which has really been focused on breastfeeding, breast milk, and lactation for mothers and babies in newborn intensive care. So I've put on the screen a list of acknowledgements and disclaimers, and I'm not going to read them all other than to say that our research team at Rush University has focused primarily on removing barriers to high-dose, long-exposure mother's own milk in the NICU. And as a consequence of that, we've had a series of grants that have been funded by National Institutes of Health, by foundations, by industry. And our current project is the one that's at the top of the list. And the principal investigators for that are my colleagues, Aloka Patel and Tricia Johnson. But as you see in yellow, what I'm going to be focusing on today is the Family Larsson-Rosenquist project that I submitted to them almost 4 years now, which was to create a toolkit or a resource kit for practitioners who work in newborn intensive care. Next slide. So just to quickly mention collaborators on the project, we're Dr. Aloka Patel, who is our division chief for neonatology and is someone who began with me as a young assistant professor and has become a human milk researcher in her own right. As well as Judy James, who's our research specialist, also a lactation consultant in newborn intensive care. Next slide. And just because we often don't think about the artists behind the project that you see here, we have Kristen Marzajan, who is a certified medical illustrator, Ron Levinson, who is our producer, director for the videos that you see, as well as Marcus Gator, who made us all look better so we wouldn't have to do so much photoshopping once we were done with the project. Next slide. So as far as background, people think, well, where did the idea for this come from? Well, the idea really comes from the gap between what is the evidence and what is practice. There's strong evidence, and it's really widely accepted globally now, that mother's own milk feeding in the newborn intensive care unit is one of the most cost-effective primary health interventions that we can offer. However, this evidence isn't routinely translated into best practices with equal care and rigor, and is too often influenced by ideology. So PROVIDE is a compendium of materials, of education sheets and videos that translate this evidence so that it can be used by professionals to engage families. The materials themselves can be used as resources for quality improvement initiatives to improve the use of mother's milk in the NICU. Next slide. So why do we need something special for NICU? Well, we need something special for NICU because both the processes of lactation and mother's own milk feedings are different from breastfeeding healthy full-term babies. And we know that globally, NICU mothers and families struggle to find evidence-based information that's specific to milk provision and feeding at breast during the intensive care unit hospitalization, as well as after. As a consequence, because this information isn't readily available, best practices for healthy full-term babies are often generalized to the NICU, which can be ineffective, inefficient, and in many instances, even unsafe. So this compendium provides practitioners with resources to teach families, standardize practice and messaging, and conduct quality improvement initiatives. Next slide. So the idea for PROVIDE really was inspired by our former Rush Mother's Milk Club, which I know probably many of you have heard of because I have spoken on this really throughout the world. This program was a translational research project, or translational research initiative within a clinical program of lactation care. And guiding everything that we did was to focus on removing barriers to high dose exposure to mother's own milk for NICU infants. And the overall tenet, and what you see here from some of our different publications, was engaging families in the science of mother's own milk and lactation. So that's what the PROVIDE compendium does. It's focused on helping healthcare providers educate families and standardize their own care using these materials. Next slide. So we're going to go through just briefly what is in the compendium, and I won't try to explain absolutely every one of the education sheets, and we're only going to see one of the videos. But the education sheets are focused on topics so that a mother doesn't get a big book of materials to read, but instead can be brought out by the healthcare professional, shared with the mother in a way that answers a mother's specific question, either that the mother has or that you want to be sure she understands as she moves into the next stage of milk provision. And the purpose of the sheets is to share them with families. They are not intended to be handouts that you just hand a mother or a father that they are going to use on their own. They're really meant to supplement the discussion that professionals have with families. Next slide. So we're going to quickly run through the education sheets. I'm going to highlight maybe 3 or 4 of the ones that I think are especially interesting and unique. And then we'll talk about the videos. So the education sheets are really divided into the categories that you see here. And they are divided as well in LactaHub into categories. So we're going to go through each of the categories and highlight a couple of the sheets. Next slide. So the first set of education sheets focuses on health outcomes of mother's own milk feeding for NICU infants and mothers. So if we can go through those. So the first of these, why does my milk matter for my premature baby? All too often, families simply get the message that your milk is important for your baby, or that your milk will help protect your baby from complications. This education sheet, which was done and custom illustrated by our medical illustrator, focuses on the various organs in the premature infant's body that are immature at the time the baby is born, and what mother's own milk does to help grow and protect those particular organs. The takeaway point from this is that these outcomes are unique to mother's own milk, not donor milk and not preterm formula. Next slide. This is one of the ones I'm especially excited about because this is focused on what is specific in mother's own milk that helps the brain growth and development of premature infants. And the focus of this education sheet is the fact that the brain during this period of time that the baby is born prematurely is undergoing very rapid growth. And the type of growth that is happening is in the white matter and the connectivity of the brain, and focuses specifically on why mother's milk facilitates that process. And again, how it's only mother's own milk, not donor human milk or formula. Next slide. Then there is an education sheet on why does my premature baby need donor human milk? And again, this one grew out of research that our team, actually was my PhD student, had done. And there certainly is a section on there about why donor milk is safe, but it focuses primarily on why does my premature baby need donor milk? And I want to be the only milk provider for my baby. I don't want my baby to have somebody else's milk. So this has, again, grown out of our research, and the focus is to educate the mothers as to why we feed premature babies so very early now, and that oftentimes the mothers themselves will have complications of pregnancy and childbirth that make their milk somewhat delayed in coming in to be able to completely nourish their infants in the beginning. So again, the focus is less on the safety of the milk or the quality of the milk, and much more on why does my baby need the milk. Next slide. And then there's one that we developed, again, illustrated by our medical artist, on how providing milk helps my own health. So we focused again on the takeaway message that lactation is meant to reset the mother's body after pregnancy and promotes long-term maternal health. And as you can see in the illustration, it shows nicely the ability of the provision of milk or the actual feeding of the milk at the breast in terms of reducing many of the preventable morbidities that are concerning for women after they have infants and as they age. Next slide. Okay, so we're going to go into lifestyle and health concerns about providing milk in the NICU. Okay, next slide. So the first of these is, again, probably one of the most common topics that we ever see in NICU, which is, are my medications safe while I'm providing milk for my baby? Now, this topic is so important that one of the full-length videos is also focused on how we can make decisions about medications in mother's milk that is intended for NICU infants. So again, I'm not going to go through the entire sheet, but it focuses on the fact that almost all mothers who have babies in NICU are going to have had some type of pregnancy or birth complication that requires medications, at least in the short term. It emphasizes that the mothers may get different information from the prescribing physician and the NICU specialist taking care of their infants, but that is the NICU specialist that understands whether the milk is truly safe for the baby. The emphasis is that it's not always on the safe side. In fact, seldom is it on the safe side to choose formula or donor milk over mother's milk. It emphasizes never to discard mother's own milk, but to freeze it or refrigerate it and ask before you do so. And there's also a section in here about how it isn't necessarily the most advisable to have a mother change medications, especially if it's a medication for a chronic condition that has served the mother very well over the years. Let's try to see if we can work with changing the dose of the milk the baby gets, or some other thing that is outlined very nicely in the video, as opposed to changing the mother's medications. Next slide. Now, I don't know globally, but this is certainly something we see in the States, but I know in certain countries this is an issue, and this is it safe to use marijuana and provide milk for my NICU baby? Again, the focus on this education sheet is that marijuana is lipophilic. It does pass into the milk, and we don't know exactly the outcome that it might have on the infant, but that we likely have a possibility of more adverse outcome in the premature baby than in the full-term population. So this education sheet, again, was designed specifically for mothers who are providing milk in the NICU and are considering or are using marijuana or cannabis. Next slide. Then this slide and the next slide are both on mastitis in the NICU, because so oftentimes mastitis in the NICU is overlooked. And mothers will interpret mastitis as sore nipples, or they interpret mastitis and don't put together the fact that they have an area of soreness in the breast and fever. So the focus of this education sheet, and if we can go to the next slide, which is identifying mastitis, this is about managing mastitis in the NICU. So if the mother has mastitis, where does she get information about whether her milk is safe for her baby? Where does she get information about the difference in the taste of the milk and the decrease in the milk supply, if that is a common outcome of mastitis? So these two education sheets, again, focused on lifestyle or events in the mother that can affect milk provision. Next slide. And then I think many of you have seen this one, and this is the special education sheet that we put together, I think it was back in March or April, about the safety of providing milk and feeding the milk when a mother has been exposed to or has COVID-19. So again, the emphasis is that the milk is important for the baby and focuses on good hygiene while the mother is pumping the milk for her infant. Next slide. Okay, understanding types of milk and the impact on infant outcome. Next slide. So these two sheets, I think, are also very interesting. And one is called What is Colostrum and Why is it important for my NICU baby? Now, I know that there are taboos on colostrum feeding really all over the world with different cultural groups or different geographic areas. And the focus of this education sheet is to take us beyond the messaging for families that colostrum is liquid gold, and into the fact that colostrum really has three intended purposes, and that's stimulating growth, maturation, and protection of the gastrointestinal tract. So the actual education sheet, as you can see on the left-hand side, shows the individual epithelial cells in the lumen of the gut that actually show how they grow in terms of number and size when they are exposed to colostrum. And then the heat map that you see in the lower right-hand corner explains to mothers how there is an upregulation of genes in the mammary gland during the very short period of time that is colostrum that appears, as you see in red, during colostrum and then never are seen again, emphasizing how critical colostrum is for the short-term and long-term health of babies in the NICU. Next slide. And then this slide, again, focuses on the types of milk that can be fed in the NICU from mothers. And it's fresh milk. In other words, it's never been refrigerated, frozen, and pasteurized milk. It explains for families what those differences are and why the storage times for them are different in terms of being different for fresh milk versus refrigerated versus frozen and pasteurized. And because we wanted each institution using these to be able to individualize them for their own practices, what we did is leave the bottom of the education sheet where you see milk type. So the institution can insert its own storage times for that particular NICU. So that again is a nice referral for mothers who are storing and bringing their milk to NICU. Next slide. NICU practices relating to mother's own milk. There are two of these at the present time. Next slide. So the first one of these is mouth care with mother's milk for your NICU baby. This is often also called oral pharyngeal care. I've heard it referred to as oral immune therapy. But what this basically amounts to is when babies are in newborn intensive care, especially small premature babies or babies that are too ill to feed by mouth, the mouth is often bypassed as the milk is fed to the baby by gavage feedings. So what this education sheet does is detail the mechanisms of protection when mother's own milk is used as mouth care for NICU babies. The photographs, again, or the drawings, again, were done by our medical artist that really depict nicely the different mechanisms of protection. And this includes basically absorption via the oral pharyngeal associated lymphoid tissues. It includes the oligosaccharides in the milk that provide barrier protection, that prevent the bacteria and other microbes in the infant's oral cavity from attaching to the mucous membranes in the oral pharyngeal cavity. And then finally, number 3 focuses on how the baby's own saliva interacts with the mother's milk to provide a special level of protection that is even more hostile to microbes in the infant's oral pharyngeal cavity. And it links this particularly to ventilator-associated pneumonias in premature babies. And there is a video, and that's actually the one we're going to show at the end of the session today, that can be used in combination with mouth care, so that the video is intended for professionals, but it can be shared with families as well. So this is first of the ones that's an associated practice with mother's own milk. Next slide. And then kangaroo care or skin-to-skin care. And there are 2 videos that accompany this education sheet. One is for the staff on how to transfer an infant who's intubated into skin-to-skin care. And the other one is for parents to assure them that kangaroo care is important for their babies. It isn't just to help them feel better about having a baby in the NICU or the closeness, but it details very nicely some of the specific outcomes of having infants in skin-to-skin care that are beneficial compared to the baby in the incubator before and after skin-to-skin care. But the diagram that you see here, the drawing that our medical artist did, really details the enteral mammary pathway and shows how when the premature baby is placed on the mother's chest, how the infant colonizes the mother's skin and respiratory tract with the microbes in the environment, that those migrate to Peyer's patches where antibodies are created. The antibodies home to the mammary gland, and the mammary gland secretes them into the milk of the infant. So basically details how kangaroo care helps babies helps reduce the risk of infection in especially premature babies, but NICU babies in general. Next slide. Pumping and milk volume targets in the NICU, and there are 5 of these, so we can maybe quickly go through these in the interest of time. Next slide. So providing milk for your baby getting started. So it talks about how if you have a baby in the NICU, you will be starting with a breast pump. It talks about holding your baby in skin-to-skin care. It talks about spending as much time in the NICU as you possibly can. So it's basically the getting started for all of the other pumping sheets. Next slide. Does the type of breast pump matter? So this education sheet is intended, again, to help staff and families understand what type of pump is indicated for what type of pumping situation, and focuses clearly that when a mother does not have a baby feeding at breast, she's completely dependent upon the breast pump, not just to remove the milk for the baby, but to stimulate the mammary gland and protect lactation over the long term, so that the pump is more than just a milk removal. It's actually a mammary gland stimulant and regulator for the mother who does not have a baby feeding at breast. Next slide. What should I watch for? We find that oftentimes mothers who are pumping for their babies tend to want to be discreet or do it quickly and not watch their breasts while they're pumping. So the focus of this education sheet is on emphasizing to the families how important it is to watch their breasts while they pump and to assure that the breasts are as empty as possible each time. And we have a number of different highly specific pumping videos as well that are the short segment videos in the PROVIDE Training Compendium as well. So we're not going to look at those today, but there are many, many of them. Next slide. What will I feel when I use the breast pump for my NICU baby? And again, this actually grew out of so many years of sitting and listening to mothers who were using the breast pump for the first time, not being aware of many of the symptoms that they were feeling as a consequence of prolactin and oxytocin that were completely normal, and they thought they were experiencing some complications. So this details for the mothers what are normal feelings when I use the breast pump for my baby. Next slide. What is a normal amount of milk to pump? Well, all mothers ask if they are making enough milk for their babies. And we actually took this idea and spoke specifically about how important it was to achieve a threshold milk volume within the first 2 weeks after birth, because of that being a period of programming for the mammary gland. So we focused on, well, why do I need to make 500 milliliters of milk if my baby's only taking this much? So we focus again on there are two targets. One is enough milk for your baby, and enough is enough. And the second target is enough to program the mammary gland to secrete enough milk for your baby over the weeks and months of lactation. But the drawing that you see in the bottom right side is one that actually came from one of our current research projects with the mother, where we're actually able to measure in real time how much time the mother spends pumping in minutes and how much milk she removes. So as you can see, it starts on day 2 postpartum and goes through day 14. And what it shows for the mother is that in the first few days, you're going to pump a lot of minutes, but you're not going to make very much milk. But somewhere around day 6 or 7, for most mothers, that reverses itself. So you become more efficient as a pumper. You're going to be making a lot more milk and spending less time pumping, so that mothers know that it's not going to be so much time and so little milk. That's just a very short phase. Next slide. Okay, so let's go now to feeding at breast during and after the NICU hospitalization. Again, a basic let's get started sheet. So what should I know, first of all? Well, what you need to know is you're going to plan to breastfeed your baby at your baby's bedside, probably, because your baby will be connected to equipment. Let your baby fall asleep at the breast while extra milk is given by gavage. So it basically lays out 9 different points about an overview of breastfeeding babies in the NICU. Next slide. And this one I think is one of the most important. I'm going to spend a second on it, again, because we have lots of videos on feeding babies at breast in the NICU, and we will be adding to these over the next 6 weeks or so as well. So the focus is on the fact that premature babies have very weak neck muscles in relation to a heavy head, so that the babies need special position to help them create the appropriate breastfeeding latch on the breast. So it shows, as you can see, the top slide shows how the mother encircles the baby's hand and provides that head support. And then there are 2 other photographs that actually show the cross cradle hold and the football hold. And the education sheet actually nicely just explains why each one of those is a suitable one for premature babies. Next slide. And then there is a slide on the nipple shield, and the nipple shield, how it helps premature babies breastfeed until they are able to create sufficient suction pressures that they can remove enough milk from feeding at the breast alone. Next slide. And again, what's different about breastfeeding a premature baby from a full-term baby? And I put this one together because of, again, just so many years of advice that mothers of premature babies get that is appropriate for full-term babies, but can be unsafe for premature babies. And one of the most common ones of those is to take off all your baby's clothes to wake him up. Put cloths on your baby to wake him up. Wake him up every hour to breastfeed if he takes small amounts of milk. So the focus here is that a premature baby is not just a small full-term baby, but he or she is also immature. The baby isn't lazy. The baby isn't just trying to not do his part. It's the baby's developmental maturity that's determining the baby's ability to stay awake and feed at the breast. Next slide. And then finally, do I need to keep pumping after my baby goes home from the NICU? And again, the graph that you see in the lower right-hand side of the education sheet is one that's taken from some of the research that we did several years ago with mothers who had taken home premature babies at about 35 and a half weeks of gestation. And we were able to demonstrate how the baby takes small amounts of milk at the breast initially, but then over that first month at home, begins to take more and more milk from the breast, and the mother needs to pump less. But the focus of the education sheet is that if a premature baby isn't emptying the breast after the baby goes home from the NICU, then the breast is not going to replenish that milk. So the pump is basically doing the job of the full-term baby by keeping the milk supply until the baby is able to feed and stay awake like a full-term baby and regulate the milk supply on his or her own. Next slide. So that's an overview of the education sheets. As you can see, we have also some videos. There are 4 full topic videos. We are going to see mouth care with Mother's Own Milk right after this. We also have short segments that detail breast pump use in a variety of settings, choosing the right breast shield, making certain that the nipple is centered in the breast shield, completing a breast assessment to assure that the breasts are emptied all around. We have short segment videos for feeding at breast, and they include the positions, they include advice for breastfeeding after NICU discharge. And there are several examples in those videos of how you explain to families why just having your baby at home doesn't mean you're going to be able to stop pumping, because the regulation of the milk supply isn't just about not being separated. It's about effective and efficient milk removal. And if the premature baby can't do that, then that milk isn't replenished. So in addition to the how to see procedures, there's also the how to explain these concepts to families in terms that they can understand. And then we also have mother-to-mother support, and there will be a special focus that we're still developing on how to help the mother's mother understand her role in breastfeeding and providing milk in the NICU. And I've been around the world in too many places to know that the grandmother either can make or break breastfeeding in any culture and country. So that's one that we're excited that we have some great footage that we're putting together right now. So next slide. So in summary, as I've said, the evidence for high dose, long exposure to mother's own milk feedings in the NICU is strong, and it's globally accepted. What I'm hopeful that this training compendium will do is to close the gap between the evidence and practice and provide materials both for quality improvement initiatives, and especially in my mind, it's standardizing the messages so that families hear the same thing from everybody, which is such a source of frustration for NICU families when they get conflicting information. The content is NICU specific, as I've said, so that families don't have to search in blogs and websites for information that's more appropriate for healthy full-term babies that are feeding at breast. And again, finally, the key tenet is sharing this information with families in a way that it's accurate, understandable, and actionable. So I thank you, and now I think we have one of the videos ready to show, and this is on mouth care.
today we're going to do oral pharyngeal care with your daughter for the first time. So I'm just going to talk you through the steps so that we're both on the same page doing it. So this is mommy's milk. It's already been checked in. Make sure it's your baby's milk and it's been warmed to body temperature. So usually what we do is the syringe packaging that we've used with the oral enteral syringe, we just put the milk back in here. It's a nice housing for it. And we use about 0.1 ml per each side of the cheek. So it's not a lot of milk, but it does the job. Okay. So I'm going to have you dip it in there, and then what we're going to do is actually you're going to swab your baby's the cheek one side, a little bit of the top gum, the lower gum, and the front of the tongue. You don't want to go back too far. And then you're going to dip it back in, get more of the milk on it, and you're going to do the other side. So I'm going to go ahead, and if you want to hold that. And these are really size appropriate for the baby too. So this is one of the smaller sizes for a preterm baby that's about your daughter's size. Okay.
You ready, sweetheart?
With these swabs, they're different than some. They don't have fibers that are going to come off, which is very nice. They're meant for oral care. Yeah. We know that all these drops of milk, especially the early milk, the colostrum, that's absorbed throughout the baby's body. It's absorbed through the mucosal lining of the mouth. And we know that because studies have been done and they actually find the properties of the milk in the baby's diaper. And this is such a pleasant experience too. Just getting to taste that warm milk. And you know, mom's milk, every time she pumps, depending on her diet, it's going to taste different each time. You know, in full-term babies, they get the breast milk when they go to breast or bottle, and each feeding tastes differently. So babies who aren't yet going to breast, or for preemies starting with bottle and breastfeedings, this is the only time that they're really getting this in their mouth. So all of the properties in the breast milk are helping to protect her. There's actually special sugars in the milk called oligosaccharides. These are actually good beneficial sugars, and they have in there wonderful properties that actually help protect your baby. Basically, it keeps the bad bacteria from entering your baby's body. The good bacteria, it's kind of like what we get in yogurt, and they call that commensal. We know that these good sugars, all this good bacteria really helps to protect your baby's mouth and throat. So it's like a protective barrier. And that good bacteria helps to keep the bad bacteria from populating in her mouth.
Just giving you a little taste of mama's milk.
Thank you, Dr. Maya, for such an informative presentation and for walking us through the PROVIDE Training Compendium. Before we move on to the next section, I would like to remind the audience that you can submit your questions by typing them in the Q&A box in Zoom or via Facebook Messenger for those joining via Facebook. Now, I'm pleased to introduce Dr. Shushma Nangia and Janet Prince, who will discuss the practical applications of the training compendium. And we are going to do this in an interview format. Welcome, Dr. Shushma Nangia and Janet Prince.
Thank you, it's lovely to be here.
Brilliant.
Thank you.
Thank you. So my first question is for Dr. Shushma Nangia. In your daily practice as a neonatal specialist, what do you see as the greatest challenges to the health, growth and development of preterm or sick infants in intensive care in relation to nutrition?
Thank you, Family Larsson-Rosenquist Foundation, and for organizing this LactaHub webinar, and for introducing and showcasing the PROVIDE Training Compendium, and for having me here. Thank you. And thank you, Arancha, for this very crucial question on the greatest challenges to growth, to health, and to development of a preterm sick infant in the NICU in relation to nutrition. What I would like to begin by saying is that we all hope that the baby really reaches term before he's born, which is 40 weeks. But then across the globe, this does not happen in about 5 to 15% of the babies who are born preterm. So if a baby is born before 37 weeks, he is preterm. But we also need to understand that prematurity is not something which is a uniform entity. It really is a spectrum of about 12 to 14 weeks. So as small as a baby is 23, 24 weeks to a baby who is 35, 36 weeks. And these two spectrum ends are very different. So whereas a baby who is 33, 34, 35 weeks could be, may not even require to come to the NICU, but babies who are 32 weeks and below certainly need to be in the NICU and under the care of the neonatal nurses and neonatal physicians. What I also need to emphasize here is that per kg body weight, newborns, preterm newborns require much more calories and much more other nutrients for their care and for them to grow. But medical specialists like me are more focused on the medical management before we start thinking of providing nutrition. And that's where the things go wrong. What needs to be emphasized is that the nutrition must be started right from the word go, which means the moment the umbilical cord is severed or cut, the baby who was receiving continuous nutrients from the mother is no more receiving them. And now if we have a time in the NICU when the baby does not receive nutrients or only receives them parenterally, that's where the issues go wrong. So what we would really want is that the baby receives enteral nutrients rather than parenteral. And within the enteral, that's through the mouth, because that's the natural way. He should be receiving mother's own milk rather than receiving donor milk or formula. Yes, donor milk does have a space that we can talk about. And why this is required is for the baby to be nourished well. Nourishment can come from parenteral nutrition as well. But the protection, the healing, and the growth and development will only come from the mother's milk. So the issue with all of us as physicians is that we start very scanty amounts, which is what is minimal enteral nutrition, and we continue that for weeks. Then we give it a very delayed start. We don't start it right away. And our increments are very slow. Somehow we've been taught that the increment of 20 mils per kg per day should be the one that should be done. And people are hesitant to increase more than that. So what happens is that the baby ends up receiving the volume of feed that he should receive early, much later. And one more malady that we all are kind of perplexed with is the pre-feed aspirates. We are trying to see, is the baby tolerating the feed or not? And that leads us to a lot of snake and ladder kind of a game. The baby has some aspirates, we stop feeding, then we restart, and that takes a much longer time for the baby to achieve full feed. So there eventually is a significant gap between what the baby requires and what we end up providing, and that takes a while. And this then results in poor health, which means the babies are more prone to sepsis, bronchopulmonary dysplasia, necrotizing enterocolitis, retinopathy of prematurity, leading to subsequently growth faltering. So the baby who was born at the 50th centile tends to tail off to the 10th centile or below, and eventually these babies also have developmental delay. So if we were to look at these challenges, what is required is to provide them nourishment using mother's own milk and start as soon as possible. And as Paula said, increase the volume to reach faster so that the babies are off intravenous fluids and intravenous alimentation and they receive enteral feeding.
Thank you. How do you anticipate the PROVIDE Training Compendium could help to address these challenges?
That's a good question. This PROVIDE Training Compendium is actually something very composite. It is made of, almost 24 information sheets, which Paula very elegantly showed her during her presentation. And they cover a lot of aspects. So what it does is, it takes care of the cognitive domains of the healthcare workers, by which I mean there is some additional information for even the person who feels, I know a lot about breast milk science, breastfeeding in the NICU, or breast milk feeding in the NICU. So even those people who think they know everything, there is some additional information which is there in these information sheets. So what I mean to say is that it empowers the people with knowledge that needs to be given to the mothers and to their peers. Then there are full videos, 4 full videos, which are talking about mouth care, which we just saw, kangaroo mother care in a baby who's on respiratory support. So when the healthcare workers watch these, then it basically gives them confidence to be able to perform. So the cognitive domain is taken care, and they also get the skill on how to perform. Then there are very small videos, small clips. They are about 32 videos, which are looking at the pumping, the pressure of pumping, the size of the breast shield, assessment of breast, and so on. So this helps the healthcare workers in supporting the mother who is pumping at the breast. So it helps them to understand what the mother's needs are and how they should help the mother in pumping. So all these put together, when it comes as a complete package, this has the cognitive domain, the skills domain, the psychomotor domain, and all the nitty-gritty of how to do things. That's what would make it that this is going to be able to address many of these challenges that the physicians and the neonatal nurses are not able to do it on their own, because they may have the knowledge, but they're not able to perform. Seeing all the videos, they would be in a better position to be able to help the moms and the babies.
Thank you. What, in your opinion, what makes the PROVIDE Training Compendium applicable across different NICU settings and geographies?
When you go through these sheets, they are very informative and they are in a simple language. So that the illustrations that are there are very learner friendly. So they aren't, heavy on science, very difficult to understand. There's nothing like that. So it's easy, and that's what will be making it appealing to people across the NICUs, across geographies. Then the videos are very well made. They are depicting the essential, crucial elements that need to be followed, and they are genuinely appealing and they're easy to follow. So again, they're not, heavy on science or something that you don't understand, or even the way they are picturized or the audio over there, everything seems to be very appealing that you want to watch the video rather than getting, not wanting to watch the video. So these materials actually cover virtually all that is required to be covered for ensuring mother's own milk to be provided to the baby, to every preemie. So as a package, the whole thing is quite appealing, and I think it can cross boundaries and it can be utilized by most NICUs across the globe.
Thank you. How do you see the evidence-based mom feeding practices presented in this training compendium being used by NICU specialists in these different settings?
Yeah. The NICU specialist, we must all realize, people like me and my NICU nurses, everyone wants to see a baby grow and go home well without any morbidities or very minimal morbidities. So when we realize that, when we read this material, when we watch the video, we find that they are very useful and worthwhile. So I'm quite confident that people would be inclined to use them, follow them, and provide the care to their babies in their NICUs, help the moms. So because the ultimate aim is that we want the baby to be growing, being healthy, and going home without any morbidities. So if we are convinced, and I am convinced when I saw all this, and people like me, the other NICU specialists are going to feel that, yes, if this is going to help our babies, why not use it?
Thank you. And how do you anticipate implementing these training videos and information sheets in your own neonatal unit?
Oh, that's a good question. So I must confess that we are already baptized and kind of converted in some sense. And we are really in awe of what Paula's been doing. And it's not the first time that I'm seeing her present her material. So the research that she's done, the evidence that has been generated over the years, and the work regarding usage of MOM in volume and the incremental use of that. So we have started working in our own unit for increasing the MOM usage as compared to formula, which we were heavily using earlier. So in my own unit, if I have to implement this, which my healthcare workers are going to find it easy to understand and implement, the only issue that I might have, or people like me in other parts of the world might have, is that they might want to translate it into their local language. And English may not be the first language for majority of people working in many different parts of the world. So that may be the only issue, but otherwise videos are quite illustrative, and it's the information sheet that might need translation. And as I said, they are not heavy on science. They are quite user-friendly and reader-friendly. So they should be well accepted. Doctors, there should be no issues. It may be with the rest of the healthcare staff that some of that might need translation into their local language. But all in all, I feel it's a great package, and it is going to, I mean, in my opinion, it's going to make a difference in the way people are doing the work till now and how they would take it further. So when they see these videos and when they see these information sheets, I'm quite confident that the usage of mother's own milk for the preemies is going to increase, and that's going to translate into better health for these babies. And the moms and the families are going to be, happier having babies who have minimal morbidity, and their survival is better with minimal any of these morbidities that I just talked about earlier. Yeah.
Thank you very much, Dr. Shushma. I've got a question for Janet. Janet, from your practical experience as an international board certified lactation consultant, why is it important that training for evidence-based mom feeding practices is openly accessible to NICU healthcare professionals worldwide?
I think that a lot of what Dr. Shushma has just been talking about, I think there are so many infants that are born prematurely every year. I mean, they're estimating that 15 million infants are born prematurely. And in developing countries, those that are born under 32 weeks often die just from a lack of these simple, feasible, cost-effective interventions. And one of these interventions is mother's own milk, and the practices that surround that, such as the kangaroo care and the oropharyngeal care that Dr. Paula Meyer was demonstrating before. And I think that it's quite often not the willingness of the staff to do these things, it's the lack of knowledge to actually how to do it, and the lack of knowledge of what to actually do. They really want to see these babies grow, but they need to learn. And I think this package will provide them with the information that they need to learn in an easy to understand format. Plus, once they've learned themselves, they can then share the information with the parents. And what I like about this is that the videos they're split, so it's very clear. Those that are for the NICU training, for training of the NICU staff. And then there's also videos that can be shared with parents. Plus the information sheets, they're easy to understand, that they are designed to be shared with the parents within the NICU and given to the parents by the NICU staff. But they also provide a very easy to understand information to the NICU staff themselves. So I think this compendium being easily accessible for all practitioners, it's free for them to use. They can download the information, they can download the information sheets, and it's available for all geographies. And what we hope is that every infant can benefit then from the protective and developmental properties of mother's own milk.
Thank you, Janet, and thank you, Dr. Shushma. Now we will open the floor to questions from participants. So I'm just going to check. Okay. I will start with the first question. If we could, do we have Paula back? Is Paula back? Muted? There we are.
Yeah, can you hear me?
Yes, we can.
Okay, my screen went blank, but as long as you can hear me, that's all that matters.
We can hear you very well. Yeah. Perfect.
Okay, great.
So the first question is for Paula. What makes these feeding practices that you've developed in a city hospital in the US applicable or appropriate for an intensive care unit in another country that may have different resources?
So that's a good question. And I think that if you are a practitioner who does not work in intensive care for newborns, that it's probably easy to think that there's a huge variability, and there's some variability, but many neonatal intensive care units, even in what you would call low and middle income countries, really are well equipped compared to other areas. So I think that the whole idea of increasing exposure to mother's own milk is one that can be adapted globally. This is, I think, the global standard. There will obviously be some pieces of the compendium that will be more applicable in one area than in another. But at the same time, one of the things I would challenge all of the listeners to think about is that oftentimes something as simple as a breast pump, electric breast pump or two that could be housed in the newborn intensive care unit are often thought of as resources that are prohibitive, when in fact that same NICU may be purchasing respirators for babies, might be purchasing incubators for babies that are considerably more expensive. So I think that one of the things I would like to have come out of this is that a breast pump is essential. It's a part of the medical equipment that we want to begin to think about as important as many other things that we think of in terms of the health economics of mother's own milk in reducing the complications of prematurity. So that's, I guess, where I would start is one thing, not all pieces can be used everywhere, but the other piece is that we need to begin to think as we prioritize resources that those that support breastfeeding and provision of milk shouldn't be at the bottom of the list.
Thank you. We've got another question. It says, this toolkit is very helpful, thank you. Is there a guide that explains which components are mother-focused and which are provider training focused?
So the actual entire compendium can be used by families. So I would say these are envisioned to be used, everything can be used by the families. And I think I would start there. It was envisioned, as I had mentioned earlier, that if we look at the research that mothers have said through generations, that the one thing they can do is provide milk for their baby in the NICU. All other caretaking activities have been assumed by other people. So why not exploit that? Why not push the boundaries on that? What can we teach mothers? What are they capable of learning about their milk other than just that it's beneficial for their babies? So that was what was behind my thinking, is what can I teach mothers that they are going to find something they can act on? Is it something that simply they can take home and show their family members and say, if it's this important for my baby, you need to help me do this? Is it something that they can take to an employer and say, this is why my baby has to have this? So where I think about this, it's something families can understand and act on. That said, it isn't to be handed out to families because the concepts in many of these education sheets and in the videos are basic scientific concepts. I mean, I showed you the heat map looking at the genetic activity in the gland over different stages of lactation. That isn't something I think you can just hand out to parents, but it provides an opening to discuss these things with the families. And each family will probably want a rollout of this in a different way. You know, right after birth, the important thing is that mothers have this sheets on why is my milk important for my baby, and getting started with colostrum and getting started with pumping, maybe those 3 sheets. And then a little bit later, you introduce something else. So it's a way of staging the developing conversation around how important milk is for premature and NICU babies. It standardizes what the practitioners share, but the end target for all of this is the families. So I hope that answers. They're all intended for the families, but they're intended to be shared with the families by practitioners who are knowledgeable.
Janet, would you like to add?
Yeah, what has also been developed within the PROVIDE compendium is a decision guide. So there are some very key questions when people are going to be looking for certain materials.
So
there are some key questions that they can answer, and when they click on the question, the right material will come up. And it will also demonstrate and show on there that I think there's only really one that's really designed for just for NICU staff, and that's the skin-to-skin care, and that will demonstrate exactly how an infant is transferred from the incubator onto the mother or the father onto the chest. And hand in hand with that, there goes another video, short video that is to show to parents of what it's all about and why the kangaroo mother care is really important and what the staff will be doing. So it is designed. It is quite clear what is just for NICU staff. And as I say, I think, Paula, that's right. There is only one that's purely for NICU staff, and the rest can be mutual for both parents and NICU staff to learn from.
Janet, that's a good point, but I think if I were, again, it's the level of comfort of the staff and the clinicians, but if I were about to do a very first transfer of an intubated baby into skin-to-skin care with the family, I would not have any problem showing them this video so that they know what's going to happen too. So, but it is meant for staff training, absolutely, as far as this is where you put the wires, this is what this person does, this is what this person does. But I think families would be very reassured if they were to see this before the transfer occurred so that they knew what to expect. So even that one that really is for staff training, I think would lend itself very nicely to sharing it with the appropriate families.
Thank you. The next question relates to what Janet was talking about, the kangaroo or skin-to-skin care. It says, does the kangaroo care video talk of the importance of a skin-to-skin and feeding free to let baby nuzzle and lick and even latch on when they can? And then it just continues saying, you've done such a great work on this over the years, love the video.
Good, I'm glad you liked the video. So the kangaroo care video focuses primarily on kangaroo care, but we do have some of the feeding at breast videos that discuss the whole idea of what we would call the licking or the tasting at the breast, as well as one of the education sheets. The skin-to-skin care video, the skin-to-skin education sheet and video are really focused primarily on skin-to-skin. And maybe I'll mention one thing here, Arantxa, that I didn't really talk about to speak of in the presentation, is that I worked really, really hard with these to keep the education sheets to one page, even with the beautiful drawings that Kristen did, or with some of the photographs that I used, to be able to economize on language and content. And that's why, for example, instead of one education sheet on pumping, we have 5 or 6 developed into topics, because they can be used at different times. So the mother isn't overwhelmed with reading so many different concepts when she really just needs to understand the basic or the getting started. So, but I think that's a good point. And I think that the question brings up the fact that we don't see the compendium as ever being done. I know I have a couple, 3 other education sheets that I want to add to it that weren't a part of what we initially decided we were going to add, but I don't see it as being done. So I'm more than willing to work on developing things that practitioners would like to have.
Thank you, Paula. Following on, the next question says, Paula, are you also thinking about a film for neonatal dads in terms of how they can support mothers?
So that is a good question too about neonatal dads. And we made a specific decision for this particular compendium to focus really on the mothers, but that doesn't mean, and I think that's a really good point, maybe we have an education sheet specifically on the fathers, and maybe even think of developing something for fathers later as a part of a video. You know, in our Rush Mothers Milk Club program, until it was discontinued, we had for several years a father as a breastfeeding peer counselor who had a baby in the NICU. So he was a father of a NICU baby who did that specific job, supporting and training the fathers. So that's a great idea. And if the foundation would like, I'm happy to work on one of those.
Thank you. Got the next question. It says, thank you very much for the excellent presentations. One major challenge is that the mothers are not able to provide mom within few hours of delivery a preterm baby. What improvement measures can be utilized? Thanks.
So this is a really good point too. And it's actually, again, where I think of what can we do in terms of improving. I think one of the things we need to do, there's evidence for very early pumping. So, you know, pumping even in the delivery room, pumping certainly within the first 3 to 6 hours if the delivery room isn't possible. So the idea of early breast stimulation, I think, is one. And I think that's why I focused the donor milk education sheet on this particular topic, if donor milk is available in the institutions where these materials will be used. Because my experience, again, with mothers over the years, really in many cultures, is that it isn't about the safety of their milk, of the donor milk. They want to be the only milk providers for their baby. It's something we talk all the time about, how the mother's one contribution is the ability to provide her milk, and then she signs a consent that somebody else can do that. So I think that that is something that is underrated as far as how traumatizing that can be for a mother. But that's one of the reasons I wrote the sheet, is because the babies need the milk so soon that this is probably the placeholder to getting to exclusive mother's own milk. But so I think two things. One is earlier intervention to get the milk, and the other one is helping mothers understand that this is the opening for donor milk.
Thank you. The next question is for Dr. Schussma. Dr. Schussma, how do you expect to track the impact on the growth and health of the very low birth weight or preterm infants that they are in your hospital after you integrate the compendium?
Sorry, after I start using the compendium, is that the question?
How do you expect to track the impact on the growth and health of the very low birth weight or preterm infants that are in your hospital after you integrate the compendium?
Okay. Yeah, that's a good question, because we do have very low birth weight infants, and that's a huge proportion that we are looking after. Since this hospital, my hospital happens to be a referral center for the high-risk moms. So of the total births, about a quarter of them require admission in the NICU. So there are a lot of VLBW or very low birth weight babies. We are currently also tracking their growth with whatever little we are doing. So we are looking at the morbidities in terms of how many develop sepsis, how many have bronchopulmonary dysplasia, how many have developed retinopathy of prematurity, and so on. And then we are looking on a weekly basis on their length growth, their weight increment, and their head circumference increment. And we are tracking this on the growth chart and seeing whether they falter or whether they follow the path. So I need not say that, yes, majority of them do falter. So once we are already tracking this, while we are doing whatever baseline we are doing, so when we bring in the compendium, we continue to track the growth and the morbidities, and we see if it has made an impact in terms of the increment, or we could just see how many have trailed off from the 50th centile to the 10th centile or even below that. So those would be the parameters that we would be measuring once we bring in this compendium, and we already have the pre-data. So that's how the impact could be calculated. And if I need any help, Paula is there to help me how to look at that.
Brilliant. We've only got time, thank you for that, for one last question. And it's for Dr. again. Is how to encourage a mother to give breast milk if a severe anemic mother is admitted to ICU? Can we take baby inside ICU and ask mother to breastfeed? Again?
Okay. So if I get the question correctly, this is a severely anemic mother who is herself hospitalized for severe anemia, and she is receiving treatment in terms of maybe a blood transfusion or some other things.
And we have the ICU.
She is in the ICU, yeah. And we have the baby in the NICU with us, right? Yeah. So here will be a situation where if the baby is well enough to feed at the breast, then we can take the baby to the mother's ICU and somebody can help the baby attach to the breast and suckle at the breast, which will have dual impact in terms of stimulating the mother's milk production as well as the baby getting the feel of feeding directly at the breast. However, if this baby is premature or he is sick and he cannot be taken to the NICU, then the alternative that we have is we pump the mother's milk and we get that express breast milk to the NICU and feed it to the baby. And we are to some extent doing this already. May not be in all the mothers who are sick for all the babies, but we are already kind of doing this for sick mothers and their babies in the NICU.
Thank you very much. Now we've reached the end of our webinar, today's webinar. I would like to give my sincere thanks to our special guests, Dr. Paula, Maya, and Dr. Shushma Nanja for your time and sharing your expertise today, and to the participants for your engagement. A quick reminder that this lecture has been recorded and it will be available soon on lactahub.thn.org. And so to close today's webinar, I would like to thank again speakers and the audience and wish you all to have a lovely rest of your day. Bye-bye.
Thank you and bye-bye.